It may be tea, it may be coffee, and whether it has a direct link to cancer. Well, cancer of the esophagus is thought to be associated with a hot beverage or a hot drink. In Kenya, cancer is the third commonest killer, and cancer of the esophagus specifically is the second commonest cancer in men and the third commonest cancer in women. Cancer of the esophagus is found in various certain regions in the country, like the Rift Valley, the Mount Kenya region, and the Western region. We visited Tenwek Hospital that has been managing patients from all walks of life from this country for cancer of the esophagus to bring you more about this killer disease.
My name is Dr. Mwachiro. I am a general surgeon and an endoscopist, and I lead the endoscopy unit here at Tenwek. My work focuses mainly on seeing patients who have all sorts of digestive diseases, but mainly cancer of the esophagus or the food pipe, which we have a high incidence or high numbers of in this part of Kenya.
A study conducted at the Moi Teaching and Referral Hospital linked the consumption of hot beverages to the risk of cancer of the esophagus, perhaps explaining why Kenya presents one of the highest rates of this cancer in the world. Gabriel Mudamba, a 45-year-old from Western Kenya, has just gone through an operation at the Tenwek Mission Hospital to manage his esophageal cancer.
Hospitali nyingi ambazo nilikuwa nimeenda kutembea kuvisit nipate matibabu, nilikuwa naambiwa ni ulcers. So nilipokuja panda hii nikafanyia huduma ya kutosha, ndipo ikagundulika ya kwamba ni cancer. Wakati huo pia akili yangu ilikuwa najua tu ni ya kwamba ni ulcers. Maanake kila daktari alikuwa akiniambia tu ni ulcers, akili yangu ilikuwa imepotelea tu hapo. Nilikuwa napewa madawa za ulcers. Nilikuwa nimekosa appetite ya chakula, nilikuwa nakohoa, mwili unakuwa high temperature. Hata nikikula chakula then haiwezi kupita, na hisi uchungu sana. Sasa zingine naweza kupitisha na maji, na ila sipisha na maji, or either nitapika itoke. Yeah. But mara nyingi ilikuwa inatoka.
Gabriel's situation is not different from the many cases that Dr. Mwachiro has seen in his time as a consultant general surgeon at the Tenwek Mission Hospital. He explains this cancer burden.
Esophageal cancer is the 8th most common cancer worldwide. But if you look at the African numbers, then that changes. So in Kenya, it's the second most common cancer in men and the third most common cancer in women. This is after breast and cervical cancer. And in parts of Kenya, we see that it's more common. So like in Tenwek, when we did an audit over the last 20 years, we saw that esophageal cancer was the #1 most common cancer. There are parts of Kenya, like in central Kenya, in the Embu Meru area, where there's a hot spot. In the North Rift, the Eldoret area, there's another spot. And then towards the lake area, Kisumu, Kakamega, and then Nairobi, of course, is another concentration of esophageal cancer cases. Most of the data has shown that high temperatures have been associated with a risk of changing to cancer. So the normal cells of the esophagus get exposed to this heat energy and they begin this transformation process to become cancer. Now, you might ask, what is this temperature? The report from IAC a couple of months ago had put out that the global average for tea was around 62 degrees Celsius. We measured our own temperature here at Tenwek and we found 72 degrees Celsius. The Tanzanians measured and they found 70 degrees Celsius. Think about it, that is very hot tea. And how we did it was we had somebody drink tea and we put something to measure, and then when they were ready to drink it, we got the average temperature. So here we think people drink very hot tea, and because of the studies that have been shown, I think that is one avoidable way that if you simply lower the temperature that you take your tea or coffee, it will have an effect on preventing this type of cancer. If you look at the global map, the esophageal cancer, especially the type we see in Africa, is common along the East African, South African belt and then goes on to China. We see squamous cell carcinoma. The rest of the world sees a slightly different type of cancer. We have been looking at a number of causes, and so we have the traditional causes, which we are aware of, like alcohol, drinking, and tobacco. But we've seen in Kenya there are slightly specific causes, like drinking of hot tea, hot drinks. Then there's a possibility of exposure to smoke from wood, firewood, or charcoal. And we think this carbon content is also driving the higher numbers of esophageal cancer that we are seeing. We've seen a strong family history or a genetic component. So when we did the Tenwek data, we found that the cancer was common in males and women. It was equally common. However, if you look at the 2018 global cancer data for Kenya as a country, they had an interesting observation in there because they had slightly more women than men. However, if you look at the average ratios, it was almost 1-to-1. Globally, the cancer is seen to be more in men than in women, if you look at the whole world, like all the numbers in general. And so I think in Kenya and in Bomet, part of the explanations that we're offering is that the women get exposure to smoke because of the cooking that they do, especially in the traditional huts, where they have these windowless huts and they are exposed to smoke every day when they are preparing food for their families, which might explain why we are seeing men and women having equal numbers of cancer. The symptoms for dyspepsia or ulcer disease mimic the symptoms for esophageal cancer, especially at the beginning stages before you get complete blockage of the pipe. And so they will come with this pain that is in their abdominal area that they cannot understand. And many times they're labeled as ulcer. So anyone who is complaining of that reflux or ulcer-like symptoms, really it's good to get a screening endoscopy done to make sure that it truly is just reflux disease and it is not cancer which is masquerading with that symptom. If any members of the public have either difficulty in swallowing, or if they notice that they are having pain with swallowing, like they realize today I was taking my food and for some reason I'm having pain, they should have an endoscopy procedure done. If you notice that you're having vomiting blood, that's not normal. You should come in for an endoscopy procedure. And the other thing which is not as common is weight loss. So if you notice you're having these symptoms and your clothes are getting looser and looser, then you should definitely have screening done for you. Okay,
Wakati nilipoona sipati nafuu, nilikuwa kazini. Ikazidi usiku sana. Nilipofika asubuhi, nikamwambia mkubwa wangu, mimi naenda kwa matibabu Narok. Nilipoenda kule Narok, wakanirefaa Pandei Tenwek hospital. Nikakuja huko. Wakanipokea vizuri. Wakanifanyia exercise nyingi sana, counseling. Sasa from there tukaanza kuingia kwa processing, yani kujua ni ugonjwa aina gani. Nilipoingia pale, nilienda kwa endoscopy kwanza. Kutoka hapo wakaniambia nikujia majibu baadaye. Maana kuna test ingine ilikuwa imepelekwa Nairobi. Ndio ikija combine pamoja na hiyo waone kama ni kitu moja. Nilipokuja ikawa kweli ni hiyo. Ya tatu wakanipeleka kwa CT scan. Ikatoa the same.
We have been seeing patients present late. So these are stage 3 and 4. But I think it's partly because of the challenges towards care that we face. Very rarely do we see patients who are really early in the disease. And to help you understand, part of it is because of the nature of this type of cancer. It grows inside the food pipe. So by the time a patient is noticing, I cannot swallow, it has grown enough to block the passage. So by definition, they come in when they are late stage patients. This makes it, of course, a bit more challenging to offer care because of the transport issues, cost, lack of diagnostic equipment. So you need an endoscopy suite where you have this procedure where we take a camera on at the end of this tube, we pass it through the mouth and we look at the food pipe and the stomach and we look for the cancer. So you need to go to an area which has that service. Many areas in Kenya are now beginning to have these endoscopy centers, but in the last 10, 15 years, it wasn't as common as it is now. So access to diagnostic services really has played a part in patients coming in late. The other thing that I would like to bring out is what I call fear or fatalistic attitude. So that means patients are afraid that if I go and they find something, I will die. Or if you diagnose this cancer, I will probably die. Or if you touch it, so we normally do a biopsy. We take a sample to confirm that it is cancer. Some people are afraid that if the doctors touch it, it will continue growing. And this these myths have fueled patients being afraid to come for care early enough when there is hope for a cure.
Aliponikalisha chini, hakutaka kunificha. Nataka kuniambia ukweli, tukubaliane na yeye, ndio matibabu ianze. Watoto wangu ndio walistuka. Hao walistuka, lakini wakakaa na mama yao wakawapatia counseling. Baba yeye atakuja kupona, msione wasiwasi. Wanaona. Nilipotoka hapa nilirudi nyumbani, nikaketi na my wife chini. Nikampatia reports zote. Nikasoma, akaniambia hapana, fanya hivi. Sasa vile umejua kiini ya ugonjwa wako, tufanye bidii tujue jinsi vile unaweza fanya nini kutibiwa.
Okay, thank you. Treatment for esophageal cancer is a team effort. So I will divide it into two. The first part is we need to diagnose the problem, and that involves multiple people. So you need somebody who is able to do an endoscopy, either the gastroenterologist or a surgeon. You also need radiologic services. So we do imaging. In some places they do a barium swallow. So they take a dye which is visible on an X-ray. So we shoot the picture and you see where it doesn't go further, and then you can suspect there is a cancer there. So you need those diagnostic capabilities. Then the second bit is now looking at the actual treatment. And so to help us understand the spectrum, I will look at the different stages that they come in. So there's curative patients, and then there's palliative patients. So those who come in early qualify for curative surgery. So this means we're able to remove the cancer and get a complete cure. If they come in very early, which is very rare in this country, we are able to do actually treatment via endoscopy. So they don't need a big operation. All we do is we put in the endoscopy, we find the area that has the early cancer, and we can resect it, or we can use heat energy to ablate or to destroy that area that has cancer, and they get a cure. So you can see we removed all his esophagus, and now we just have stomach remaining. So the new food pipe is now what used to be the stomach. When the cancer has grown more, it is not just on the surface, it is involving more of the food pipe, so it is growing into the wall of the food pipe. Then now you need to have a resection. So you need to remove that part. And this involves having a procedure we call an esophagectomy. So esophagectomy means removing the esophagus. It's a long operation, and you need to, first of all, start with opening the chest. We free the esophagus, and then we open the abdomen. We free the stomach, and then we remove the part that has the cancer, so all of the esophagus comes out, and a little bit of the stomach. And then we pull up the stomach to form a new, this will become the new food pipe. That's what they'll be eating. And then now we make a repair, a surgical repair. The third bit is patients who come in late. So if you come in fairly advanced, then there are two options. One is, are we able to try and shrink this cancer? And so now I'm introducing the concept of working with our oncology colleagues, because for many of these cancers and esophagus, as we've seen, if you do chemotherapy and radiotherapy. So chemotherapy is we inject a drug in the veins, and that shrinks the cancer. And radiotherapy is they administer heat energy to X-ray energy to the part that has the cancer to try and shrink it. We've seen that it is able to become smaller and makes the surgery much easier. So for some patients, they're able to benefit from that, and they can still be offered surgery. The last category is patients who come in so late that the cancer has now grown not just into the food pipe, it is now involving the heart, the breathing pipes, and it is now difficult for you to remove that cancer without endangering these patients. So for this type of patients, then they qualify for palliative care and hospice care. So mainly in Kenya, the options are either you get palliative chemo and radiotherapy. So essentially we try and treat you to shrink the tumor and stop it from spreading, even though we already know it has gone to other parts. The second bit is these patients now need nutrition because they cannot swallow. The food will not get to the stomach.
In the event that cancer of the esophagus is not diagnosed early, there are other ways of managing the patient to improve their quality of life. The use of stents as a palliative treatment for esophageal cancer is largely due to diagnosis at very late stages where curative treatment is not possible.
This is an esophageal stent. It's what we typically call a self-expanding metallic stent. As you can see, it's very pliable, and the reason for that is for us to deploy it into the food pipe, we have to load it. They come with a delivery system. So you can see these are sample stents that have not been opened. So essentially this gets loaded into this, it is able to shrink down, and then we introduce that into the food pipe, and once we deploy it, it opens again to this position. And the whole concept of this is when you have an obstruction in the food pipe, then you put in the stent, it opens up and allows food to cross from above the area that was blocked to the stomach. So this allows the patients to have nutrition, especially for patients who are palliative, who we know that for sure will not be able to offer them anything else. Occasionally we also use it for patients who come in and they could be surgical candidates but are not in good nutritional status. So we put it as a temporary feeding aid to help them to feed, and then when they get better nutrition, we put them through the procedure. This stent gets embedded into the food pipe. So what that means is there's a part that is coated, which will not have any tissue around it, and then there's a part on these ones is the top part, which does not have a coat, and the tissues will grow around it and hold it into place. When you do the surgery to remove the tumor, we usually remove the tumor and the stent, and then we discard it and the tumor is sent for pathology. If the tumor is very low, so if it's near the stomach, occasionally this will hang into the stomach, and those patients have to deal with the problems of reflux. We put them in endoscopic, so there's no surgery involved. We simply do the endoscopy procedure, so we pass this camera, we put a wire, and then we deploy or we open the stent, and it keeps the food pipe open and they're able to eat. In some areas where there is no access to these stents, then they have to do a feeding tube via surgery. Of course, these patients normally are very weak and frail, and so we've seen, especially in our experience here at Tenwek, that they have difficulties with that type. So we've mainly been doing the palliative stents as a way of offering nutrition. The last component of this whole treatment is now the hospice care, because these patients need support. They are having pain, they are having troubles with nutrition, and so in Tenwek we have a program where we enroll them and we go out to their homes. We visit them in their houses after they've had the procedures and we check on them. If they need to have pain medication, we prescribe for them the morphine and they're able to access that, and we also generally see how they are doing.
Daktari alinielezea kwamba kulingana tumekupima na tunataka tupeleke theater, naenda kutoa pale shida iko na turekebishe, utarudi kwa normal. Na hivyo ndio walifanya.
We've had a number of patients opt to get the conventional medical treatment, but still at the same time go and visit either the herbalist or the traditional, especially here in our setup, there are these traditional healers, if I can call them, and a number of patients opt to go for that treatment. But I think if you look closely, that really shows us that the patients are looking for hope. They are trying to find, is there something else that I can cling on, that I can help me handle this new cancer that I've just been told I have. Loss to follow up, this means patients who go away and don't come back is an issue, not just for palliative patients, even for some where you catch it early when you tell them about the diagnosis and you go over the different treatment options, and then they say, well, let me go and talk to my family, and sometimes you don't see them again. They go and they are simply afraid to come back. And so that's one thing we need to keep telling our public, that if you have these symptoms, this, if caught early, can be treated and can be cured. And if we are unfortunate that we catch it late, then we work with the patients to help them to manage their disease. This is actually good. I honestly don't think we need to go any further. Yeah, exactly. Yeah, so it looks like everything was working fine. What we have discovered over time, because in the 20 years, 25 years, we've learned that on top of offering the palliative care, how do we help to give hope even to the relatives and the caregivers? Because one of the things, and we see it in clinic, when you tell a patient you have cancer, and automatically the family start wondering, oh, what about me? If this patient has cancer, I could get the cancer. And so we have started, and we've been doing this screening exercises where we offer, if you have a relative who has cancer, we want you to come in and get a screening procedure.
Kulingana na mimi, jinsi vile nilivyojua, watu ndio wajui. Unaona? Na saa zingine, unajua madaktari wako tofauti. Unaweza kwenda kwa kuambia analysis, unaanza kupoteleshea wakati wako pale bure. Kumbe sio hiyo. Unaona? Lakini kama ungekuwa na vifaa za kutosha kama Tenwek hospital, unaweza kupata matibabu kwa njia haraka sana.
How can we catch this cancer early? And especially in Kenya, if you look at the global can data from this year, the high numbers, the new cases was almost equal to the patients who are dying. So we need to reduce that gap, that as much as we are catching them, the patients who are dying, that number should become smaller. And so we have been working on early detection programs. And one of the earlier studies that we did was we went out to the community, we explained to them this issue, and we brought them in for screening endoscopies. So for you to be able to do early detection, because of the nature of this cancer, currently we can only do that through endoscopy. So the patient comes into the endoscopy unit, we pass the endoscopy machine into the food pipe, and similar to cervical cancer, we spray the food pipe with Lugol's iodine. The areas that do not have cancer will take up the dye. The areas that have cancer will not take up the dye, and that's the area you focus on. And we've been able to offer, because then you can offer endoscopic treatment, so we can remove just that portion, and this is able to offer them early treatment. You can see that's where the stomach, what was removed, and the new esophagus, so the stomach. We're looking back at ourselves, that's the junction, and you can see that's where we did the suturing of the esophagus to the stomach. So we connected the two with sutures, yes. And then I'm going to go back to normal view. I think we need to work on having more specialists, not just people who can remove the cancer surgically, but also the medical oncologists, the radiographers, because for you to properly diagnose this cancer, you need each of those, and to treat it, you need the surgeon, the gastroenterologist, the oncologist, the radiographers, and the support services. So one way that Kenya is growing as a country, and I think already a number of centers are offering these types of training, is having more specialists being trained to deal with this cancer. Here at Tenwek Hospital, we recently started offering training in cardiothoracic surgery because we noticed that need, and now we are focusing how can we increase the number of surgeons who are able to offer this type of surgery. The other bit that I see with room for growth in Kenya is simply having enough centers that are able to diagnose. As we talked about earlier, many patients come in late because they're being sent from one area to another as they're trying to figure out what's wrong with this patient. So if we had each of the counties have in their county hospitals a wing that is able to offer diagnostic services for esophageal cancer and curative services for esophageal cancer, that really is the future, so that people don't have to travel. We've seen patients who've come all the way from Kwale to our hospital here in Bomet. We've seen patients come from Kakamega to our hospital here in Bomet. So if we had these services available in the different parts of the country, then that would really save costs and time. The last bit is what I call research and innovation. And so we want to be able to offer world-class care in Kenya. as other parts of the world. If we as a country can allocate funding and resources to those components, we will be able to reduce the burden and reduce on those graphs the people who die. That fraction can really shrink as opposed to the number of new cases that we catch.
Kansa ni kama tu ugonjwa mwingine wa kawaida, kwa sababu hata kama ni malaria inaua, si ndio? DP inaua, ugonjwa wote inaweza kuua, so that's why sisi kufeel, unaona. Lakini daktari wangu akaniambia, akanipatia counseling, pia akanipatia raw.
One of the things that we have tried, and actually over time now we've got more buy-in, is helping patients to understand that when you get the cancer diagnosis, that does not simply mean that's it. You know, if we are able to work together, in as much as you are in especially if you catch it late, you are still able to have a better quality of life. And so this, for us, has meant being more engaging in the discussions. And actually, in our endoscopy department, we have a staff chaplain and the social workers who work with us with these discussions. They help us to explain the diagnosis to the patient, explain the changes in lifestyle that will happen, because when you put in these stents, it allows them to have a more dignified way of life.
Saizi, naweza kula, naweza tembea, naweza hata cheka, unaona, lakini wakati huo sikuwa na furaha sana because tulikuwa na feel a lot of pain. Singeweza kukula, sina furaha, nimekata a lot of weight.
Imagine if every day you cannot swallow even your own saliva. You've seen when the patients come in, they have this little plastic bag and they're spitting into it. And now when you put in the stent, at least they're able to feed, they're able to maintain their nutrition. And even the family see it is much easier because they can take their pain medications, they're able to interact better with their caregivers and their relatives.
Nimepata changamoto na niko na experience sasa ya kutosha. Hata nitakapotoka hapa hivi, hiyo ndio habari ambayo itakapopelekea nyumbani kwa villagers. Mtu kama wa aina hiyo asije akaketi tu ya kwamba ati ni hali sasa, hapana. Anatakana ajue jinsi alivyo, anaweza kwenda pahali ama anaweza kwenda kuja na yeye huku apimwe, kwa sababu kuna facilities za kutosha. Kama ni hali sasa, utaambiwa ni hali sasa, ni kweli. Manake madaktari hapa hawabahatishi. Kama ni kansa atakwambia ni kansa, alafu unaanza kwenda step by step, unapata uponaji.
Kenya is one of the leading producers of coffee and tea in the world, and as a country, our fondness for the hot beverage is almost unmatched in the region. Kenya, as a developing country, increasingly continues to bear the burden of cancer. And while one may be genetically predisposed to some type of cancers, doctors advise against lifestyles or habits that increase your risk. So, next time you reach for a hot cup of your favorite beverage, think about it before you take that sip.